if you allow me to move to the next speaker, Professor Hossam Afify. Professor Hossam Afify is an adult critical care anesthetist or medicine professor. Professor Afify will talk about very crucial issue. First of all, I should tell that he's working in the King Abdullah Medical City in Makkah, Holy Makkah, Saudi Arabia. And he will talk about the very crucial issue regarding POCUS or role of POCUS, point of care ultrasound in AKI. As we are nephrologists, we are using this ultrasound in the assessment of the AV fistula, in the lung ultrasound to assess volume status, to assess, to help us in inserting the needles for dialysis patient in the difficult cannulation, and so on. So we shall hear to a very fruitful lecture from Professor Hossam. Please, the floor for you, Professor Hossam.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullah. Is it my voice is clear, Professor
Yes,
Hamid?
sir. Yes, clear.
Bismillah wa salatu wa salam ala Rasulillah. First of all, I want to thank Professor Khamis, Professor Saad Mahdi, and all of my colleagues to bring me here in this valuable day. My lecture, inshallah, about using of point of care ultrasonography for acute kidney injury. First of all, I want to say it is not ultrasound workshop course. I am not a radiologist. I am not a nephrologist. I am critical care consultant, but I have a dream. That dream is to improve the global outcome of acute kidney injury, especially in my patients in the ICU, the critically ill patients. I have no conflict of interest. However, I used and I shared a lot of slides and a lot of ideas from my professor, Walid Shibr, and I used also some ideas from a very valuable POCUS website. The objectives of this lecture is to explain the role of POCUS in acute kidney injury and to discuss with each other a new ultrasound-based approach in acute kidney injury. We'll start by case. Mr. Mahrous is Egyptian patient. Mahrous by English is Mr. Protected. He's 40 years diabetic, hypertensive, diastolic dysfunction, chronic back pain, or non-steroidal anti-inflammatory. Came to the ER complaining from SD fatigability. His creatinine was 10 and diagnosed as acute kidney injury on top of chronic. However, another case admitted to our ICU, Mr. Saber al-Masri, or the Egyptian patient, as I translated, is a 70 years old male patient, 70 kilos, BBH, diabetic, hypertensive, AFib, ischemic cardiomyopathy, ejection fraction only 15. Admitted to ICU after exploratory laparotomy, after ischemic bowel, and explored, they found gangrenous bowel. After resection anastomosis, we received this patient in our ICU, hypotensive, intubated, on vasopressors. His lactate is normal, his kidney function is okay, and urine output accepted. However, there is two types here of acute kidney injury. We have Mr. Mahrous, which came from the community. He is, and with clear history, he is using drugs on top of chronic, maybe diabetic nephropathy. It's community acute kidney injury, community acquired. However, the other patient came as hospital acquired acute kidney injury. The big challenge or big dilemma, why the outcome of acute kidney injury is poor in the hospital acquired acute kidney injury, is the conflict about the definition. Now, Cadico definition simplifies this one into stage 1, stage 2, stage 3. 1 is a stage of ones, means it is very simple to remember. 1 is 1, 2 is 2 doubling, and 3 is 3 times the creatinine. The other change in the Cadigo, rather than the rifle, is the removal of risk. Why is they remove the risk? Because all of our patients at risk, all our patients like Mr. Saber al-Masri. So all our patients in the critical care are having a lot of risk factors and the causes. It's multifactorial, containing sepsis, volume overload, hyperperfusion, using nephrotoxic drugs, antibiotics, vancomycin, colistin, multifactorial contrast using to diagnose. Also, the outcome is different between community-acquired acute kidney injury and hospital one. However, the community-acquired is lower incidence of oligoria, lower incidence of ICU admission, shorter hospital of stay, less mortality, and better prognosis. The hospital-acquired acute kidney injury, high risk of readmission, high risk of mortality intra-hospital, and 90 days mortality, and even within 1 year from the discharge from ICU, there is risk of mortality. Hospital-acquired mortality, hospital-acquired acute kidney injury mortality 10 times more than non-AKI critically ill patient. And the mortality is more in septic shock and increasing C-reactive protein. Another dilemma causing a conflict of management, they're using this algorithm all the time for diagnosis of acute kidney injury. It is naive algorithm, very, very basic, pre-renal, entrancing, and then post-renal. Only can be used for community-acquired acute kidney injury for Mr. Mahrous. Straightforward case, chronic kidney disease on top, and then on top of it is acute. We have a clear pathophysiology. But Mr. Sabri al-Masri is a conflicting case. He had a lot of risk factors. He had diabetes, ischemic cardiomyopathy, maybe cardiorenal, maybe sepsis because we have bowel ischemia and bacterial translocation, hypotensive and vasopressor. So the condition of Mr. Sabri al-Masri is a combo. Combo means he has a sepsis, is a big part of pizza, but can also containing some other causes like using vancomycin, colistin, contrasts, yes, maybe obstructive, maybe they ligated the ureter during OR. Another problem leading to conflict of management and delay of management and poor prognosis using Stampa. Stampa management, Stampa is the Italian word, very common to be used in Egypt as copy-paste, using the management for the same patient, the same. For Mr. Sabri, like Mr. Mahrous, treat the underlying, the secondary AKI, treat the underlying cause, proper treatment of the sepsis. How to treat the sepsis without using nephrotoxic? The next statement, avoid nephrotoxic. How come to treat the sepsis without using vancomycin, without using colistin, without shifting the patient to do contrast? And then avoid volume overload, avoid using diuretics. And in the bottom of the list, they put POCUS, all ultrasound to rule out the obstruction. This delay leading to confusion, and the confusion can kill. So what's where we are in need? We are in need of one tool to fit for all. We need one tool to help us to identify our patient at risk, to help us at early proper management, and also sometimes to help in prognosis. Point of care testing is a lot of testing, including blood sugar testing, ketones, ABG, CBC, and point of care sonography. The difference between point of care sonography and radiologist-based or performed ultrasonography is who will do POCUS? The frontliner, me and you, the critical care physician, ER physician. However, the radiology performed ultrasound usually used by radiologists. So the time is less with the POCUS. However, when you want to request the REPOS or radiology performance, it will take time from requesting, consenting, shifting the patient, or shifting the physician to the ICU. The last very important difference between POCUS and REPOS is the focusing. We are focusing on certain radiological questions. I need to answer single or focused radiological question. Is my patient had obstructive neuropathy? Is my patient had hemodynamic renal failure? Is that patient having sepsis and he's in septic shock, and where is the source? However, when the radiology will come, he will put for you comprehensive assessment for the kidney, whatever the underlying etiology. So a lot of evidence supporting using a POCUS in ICU because of POCUS reduce the time needed to identify a patient risk, reduce the time triage to final destination, rapid turnaround of the results, allow reduction of the time to proper intervention, finally improving morbidity and mortality. Let us go to some basics. This is the ultrasound, or this is the sound line. The acoustic or the hearable sound is between 20 hertz to 20 kilohertz. Infrasonic, less than 20, not heard by human ears, and usually for elephant communication. More than 20 kilohertz to 2 megahertz for bats. However, from 2 megahertz to 5 megahertz, usually for curvilinear ultrasound probe or phase array echo probe. And more than 5 to up to 7.5 for linear probes. More the frequency, less the penetration. However, less the frequency, more penetration. Can be also the frequency more up to 200 in radio destructive therapy. Ultrasound reflex. Ultrasound reflex, like any reflex, is a stimulus, and then afferent, and then brain, and then efferent, and then proper action. The ultrasound is here in synapse and afferent. Our ultrasound machine has no brain. Please use your own. So the reflex started by this physician connecting power to this machine. The electricity hitting piezoelectric crystals, inducing waves. This waving reflecting back to the piezoelectric and then transmitted into a view or a radiographic image. It is not complete reflex. To be completed, should have stimulus. The stimulus is proper radiological questions. What I want from the machine, what I want to expose this patient to a high risk of infection and expose my team and bring the ultrasound machine inside the room for what? What is the risk benefit? What's my question? Is this patient had obstructive neuropathy? It had renal failure second to heart, cardiorenal, or he is in shock? So I should have clear radiological question. If I have not clear radiological questions, better not to bring the machine inside the patient. To complete the reflex or ultrasound reflex, I should have proper response. This proper response based only my answer of this question. Is it yes, I have obstructive neuropathy, so I should take a proper action immediately? Or no, there is no obstructive neuropathy, I will search for other cause of acute kidney injury. Or I don't know. So I don't know, I will call for help. But this answer not including maybe. No maybe in this answer. So a confusion can kill. Please not hesitate to repeat, not hesitate to call for help. Let us to practice. Our proposal or approach is 1, 2, 3, 4. 1 probe, 2 modes, 3 positions, and 4 questions. 1 probe will select from all of these probes the curvilinear. Why? We have the frequency here from 2 to 5 megahertz. However, the phase array is the same, so less frequency, more penetration. However, the footprint allowed to detect a large surface area of the kidney. 2 modes. We have 2 modes. The bright mode, we will use it in the POCUS. The bright mode or B mode, in which the ultrasound probe, when stimulated crystals leading to producing a wave, reflected back to the probe. This reflection of the wave depending on what's called acoustic impedance. This, when there is fluid, less acoustic impedance of the blood, allow more transmission and passage of the waves through the fluids and less reflection. Less reflection leading, producing black color, which is caused by fluids like blood and urine. More acoustic impedance, more reflection, more brighting. So the soft tissue appearing like the liver as like this. However, the fibrous tissue appearing more whiter because more acoustic impedance and more reflection of radiological ultrasound waves. Finally, the stone and bone, more reflection, but also not allowing any radiological beams to pass behind it, leading to what's called acoustic shadow behind the stone. To apply this one in our kidney, the kidney normally appear like this. We have a cortex, the same or less echogenic, like a liver. We have a fibrous band with hyperechoic because it is containing fibrous and high impedance of the fibrous, and the renal sinuses, which is the containing the which containing fat, and so it looks like hyperechoic. Some renal pyramids which containing urine looks like it is black and it is hypoechoic. Then the second mode is the Doppler mode. When using the Doppler mode, we are first we are bringing the 2D mode and the bright mode, and then color Doppler, and putting the sample. We are seeing here a mosaic view of the arteries and the veins because it is overcrowding circulation here. An artery, it looks like red, and venous, which is the blue. And by putting the Doppler ultrasonography, we get this view. Three positions is to get the kidney. We need to put the patient either in supine, lateral, or prone position. In the supine position, in the mid-axillary line, just below the rib cage, I can see the kidney through a liver window. But lateral can be used in the clinics or outpatient. Most interestingly, we can assess the kidney even in the prone position. Most of our patients nowadays, because of COVID and because of prone positioning in the ERDs, they are in prone. We can assess the kidney even the prone by this window between the rib cage and iliac crest and the paraspinous muscle. What is the 4 questions we should know? 1, 2, 3, 4. What is the 4 questions? The 4 questions, first of all, we need to ask ourselves, is my patient in shock state? Is in shock or no? The second question, is this situation is acute or chronic? It's acute renal failure or chronic renal failure. And the third question, is it obstructed renal failure or not obstructed renal failure? The fourth question is the hemodynamic assessment of the kidney. First of all, the shock state. Like we are teaching our colleague and our fellow residents, if the ABC, if there is shock, please neglect an AKI. Focus on the shock. Identify the cause of the shock by using what's called the rapid ultrasound shock protocol or rush protocol, plus using echo for the heart to assess the VTI. Rule out the pericardial or tamponading effusion, an RV affection or RV strain, a VTI assessment, IVC assessment, it is collapsed or full, and then pleural effusion and a Morris pouch for free fluid in the abdomen, aortic dissection, and pneumothorax and tension pneumothorax. The shock assessment out of the scope of our lecture, but please, if the patient shock, not to ask why is the patient in AKI. To read the shock, identify the cause, proper in the rapid way. The second question, is it acute or chronic? Why I want to ask myself, it is acute or chronic? Most of the chronic cases are underlying etiology is chronic. So if you control diabetes or hypertension, it will not improve the chronic kidney disease. It will decreasing the transmission of the acute kidney disease to end-stage renal disease. It will decrease the need of dialysis. But in acute, it is very important to reverse the reversible causes in very tight time window. So first of all, we need to assess the size of the kidney. The length of the kidney is about 10 centimeters from ball to the ball, and the thickness of the cortex only one centimeter. the cortex from the fibrous capsule to the base of the renal pyramid. So normally you very uncommon to see gentlemen younger than 60, his kidney less than 10 centimeters. Another way to differentiate acute and chronic is the echogenicity. Usually, the echogenicity of the kidney is less than the echogenicity of the liver. If it has become more echogenic, more like liver, it is most probably it is a chronic kidney disease, but not totally chronic, can be acute or ETN. If we put both together, increase the echogenicity with decreasing length, يعني decreasing the size, length less than 9, and the cortical thickness less than 0.7, with echogenicity maybe higher than the liver, it is a chronic kidney disease. However, increase the echogenicity with preserved length like this may be infiltrative, multiple myeloma, lupus nephritis, glomerulonephritis, or diabetic nephropathy. The third question is, it is obstructed renal failure or no? Hydronephrosis is a late sign of obstruction. So can be found, it is obstructed uropathy without hydronephrosis. But if present, it will, grading of hydronephrosis is correlated with the severity of the obstruction and affecting the triage of management. Means if I found in the ER, it is just mild hydronephrosis 1 to 2, the triaging maybe in the ward, and later you can do CTQB. However, if it is severe hydronephrosis like this, with loss of a differentiation between the cortex and the medulla, and the loss of anatomy of the kidney, it is need immediate in the ER to put nephrostomy tube or to bypass the obstruction in the ER without even shifting him to the ICU. Assessing of the cause of hydronephrosis can be detected easily in the stone in the pelvis, but sometimes not detected. The stone appears as hyperechoic with some acoustic shadow behind it. The same here. We have found hyperechoic mass, but without acoustic shadow, it is not a stone. It is a complicated pyelonephritis or abscess. The obstructed uropathy not completed except after assessment of the bladder. The bladder outlet obstruction, it is not acute, can be chronic, but some scenarios can be acute, like postoperative radical cystectomy, TURB and bleeding, and some of urine or hematuria obstructing the neck of bladder of the urethra, of the urethra, and very common scenario in ICU to find this sign: Foley and full, Foley catheter and full bladder. This means the Foley catheter or the urethral catheter is not functioning, need to be replaced or flushed. The fourth question is the hemodynamics. And to understand the hemodynamics, we need to go to some basic. That basic is that the final pathway of acute kidney injury, usually due to decreasing the glomerular filtration rate. Decreasing glomerular filtration rate is caused really by decreasing renal blood flow and decreasing renal perfusion pressure. Renal perfusion pressure is affected by two elements: the main arterial blood pressure and venous pressure. Decreasing in MAP or increasing venous pressure can decreasing renal perfusion pressure and leading to acute kidney injury. The MAP is a product of systemic vascular resistance and the cardiac output. And finally, the cardiac output is a product of systemic stroke volume and the heart rate. The venous pressure can be affected by heart failure, volume overload, and by intra-abdominal pressure. So, using of ultrasound here can be beneficial. I can use it in this side, which is the arterial side, to assess the stroke volume, which is out of scope of our lecture, but it can be, and cardiac output assessment of the renal vessels by resistive index, and then assessment venous blood flow, and this can be caused by intra-abdominal or volume overload. Simplifying, we can classify hemodynamics renal failure into ischemic renal failure or renal angina, or congestive renal failure or renal tamponading. In renal tamponading, primary insult, which is the inflammation or it is sepsis, leading to releasing of interleukins and apoptosis and leading to more inflammation, more fluid accumulation in this tight fibrous band, leading to renal compartmental syndrome or renal tamponading, ending by irreversible damage. To assess hemodynamics for kidney, we need to get firstly the 2D bright image and then color Doppler. After color Doppler, we should put the sample of the sample volume on the artery first or the vein, but it is difficult here because overcrowding vessels. So usually we get a picture of mixed. Above the line, it is arterial waveform, and below the line, it is a venous waveform. The arterial waveform, it is usually systolic and diastolic, pulsatile. However, the venous waveform usually continuous like this. Let us start by arterial assessment or resistive index. A resistive index simply is the differentiation between systolic, the top, the bottom, divided by the systolic. So it looks like ejection fraction of the kidney. The normal resistive index is 0.6. However, more than 0.8, this means very high or high resistive index, and in the severe renal stenosis, maybe dumped even wave. The differential diagnosis of resistive index is transplant rejection, very common in our hospital. We should monitor our patient post-renal transplant by resistive index, obstructive uropathy, ATN, pyelonephritis, severe hypotension, and acute vascular event or venous or arterial thrombosis. The second element of hemodynamic assessment is the assessment of venous wave. Usually, a venous wave like this, continuous venous wave. However, there is a multiple pattern of venous correlated with the increase in right atrial pressure. So more heart failure, more volume overload, the change of the pattern from continuous renal flow like this into at first pulsatile, systolic and diastolic, and then the systolic may be notched more, and finally ended by monophasic diastolic. More increasing of the pulsatility and the more increasing of the monophasic is corresponding to more congestion and more heart failure or volume overload. In this Brazilian study, they found the patient with acute kidney injury with positive balance associated with more mortality more than the acute kidney injury with no positive balance. And in Japanese trial, they found a strong correlation between the monophasic pattern of the renal blood flow and the high CVB and the high mortality and poor outcome. Finally, it is a big correlation between the assessment of hepatic vein, portal vein, and IVC and renal vein, and all of this combined in the newly developed score called VEXAS score. VEXAS score simply can divide into 0 when I assess IVC and I found it is less than 2 centimeters, most probably no congestion. If the IVC diameter more than 2 centimeters with combo of mild or abnormal pattern, like presence of abnormal pattern of hepatic vein or portal vein or renal, it is moderate, and then it is more to severe pattern, it is severe congestion. Why I should know is the severity of congestion, because it's related to my way for management, either to using diuretics or to start CRRT or to do deloading of the right ventricle. Finally, home take message to time is tissue. Delay in the management of acute kidney injury is leading to poor prognosis, morbidity, and mortality. Yes, POCUS is valuable in acute kidney injury, but need not only training, but also needing to some focusing, to have some clear question you need to answer it, And the answer also should be focused, cleared. It is yes or no, or I don't know. And if I don't know, I should go for more training and more courses for ultrasound. Using approach is very important, like 1, 2, 3, 4, one probe, 2 modes, 3 positions, and 4 questions. If you haven't any answer of question, do not hesitate to call for help. Thank you very much.
Thank you, Professor Hossam, for this very elegant presentation. Actually, we learned a lot from this. If you allow me to read the questions on the chat from Dr. Mahmoud Rabia, is fluctuation of venous flow called respiratory viscosity? I hope that I read it in a proper way.
There is some fluctuation of the continuous intravenous flow with the respiration, but it's a minimal. And in ICU, usually with ventilated patient, by decreasing the respiratory rate or make like a pulse, we can differentiate between the respiratory fluctuation and the hemodynamics fluctuation.
Okay. I have 2 comments. The first comment regarding the patient, like the second patient, Saber al-Masri.
Yes.
As you mentioned, here multifactorial, almost the usual or common scenario we face.
Yes.
As you said, so we cannot rule out hydronephrosis from real-time ultrasonography at the beginning, on the first day, because sometimes the patient came with dehydration and they need volume repletion, and after repletion of the volume status, you will find the patient, if you repeat after a while this renal ultrasound, you will find the hydronephrosis is there. So we should not miss, I think, to repeat the ultrasound after a while after volume repletion. What do you think, sir?
My point, we can use the ultrasound routinely in ICU by approach way. What's the meaning of that? Before acute kidney injury, we have a phase called pre-acute kidney injury. Yes. This Mr. Sabr Basri came with the normal kidney function, by the way. High risk factors, multifactorial with normal. However, of that, I should monitor him daily in my round by using the POCUS. Assessing of the approaching resistive index, there is hydronephrosis or no, volume status of the patient, the hemodynamic assessment from the stroke volume, mean arterial pressure, and the resistive index, even with normal kidney function, Dr. Khamis. Because early prediction of the patient with high risk, improving the management timely and improving the outcome.
Right, you are. Second and last comment. In the last 10 years, as you know, the role of lung ultrasound was raised in the field of in the ICU and even the nephrology field and so. So, is there any role of the lung ultrasound as a POCUS in the AKI patient?
Yes, there is a role of lung ultrasound, but not involved until now in this PHEXAS score. PHEXAS score is involved in IVC, portal and hepatic vein assessment, and renal vein. But they didn't put the ultrasound for critical ill because there is a multifactorial for B lines in this one. Can be heart failure, yes, but also consolidation can be there. To assess the volume status only from the B lines in the ultrasonography of the lung, I think it is need more support by assessment of IVC, portal vein, hepatic vein, and renal vein. Not only the lung.
Yeah, right. Okay, thank you, sir. Thank you for you and